Hello, everybody. Welcome back to another installment of Ethics. So what we are going to do today is, today actually we are going to change the focus of the class. Let's review what we've done so far. In the first section of class, we talked about the different approaches to moral realism and to moral decision making, right? In the second part of class, we talked about the different ways of conceiving of the relationship between the individual and society, right? And we talked a little bit about political philosophy, right? So in this third part of class, now we are going to be taking what we learned in the first two parts of class, and we're going to be applying what we learned to modern moral issues, right? We're going to be looking at a variety of moral issues that we face today in the USA, and maybe elsewhere. And we're going to be applying the theories that we've learned to try to help us better understand and maybe better make some moral decisions on issues like abortion, birth control, population control, immigration, and so on, right? Today we are going to begin the discussion by talking about James Rachel's article, Active and Passive Euthanasia. So let's talk about this word euthanasia. That's the topic we are discussing today. Euthanasia is the practice of ending a life to avoid suffering or to relieve suffering, right? So if you end a life just for fun or because you want the insurance money, that's just flat out murder. But ending a life specifically for the purpose of avoiding or bringing an end to somebody or your own suffering, that counts as euthanasia, which comes from a Greek word meaning good death, right? So this is a particular issue in the modern era. We have different kinds of technology and medicine that is extending our lives more and more. More and more people are dying in a hospital setting. As such, more and more people are facing the question of what they want the end of their lives to look like, and doctors are facing moral questions about to what degree they and under what circumstances they can be involved in ending a life for the purpose of avoiding suffering, right? So let's take a familiar, it's probably a familiar example. Say someone has cancer, and you've gone, and the patient you've gone through, say you have cancer, you've gone through a long period of fighting off the cancer with radiation treatment and chemotherapy and so on. The cancer is gone for a while, it comes back, it goes away for a while. And now you go into the doctor for a checkup, and the doctor realizes that the cancer is back, it has spread again, and it's spread in fact to your brain. He says you're facing a few more weeks. You're within a few more weeks, you're going to be dead. What we can do, however, to buy you a little more time is we can go back to the chemotherapy and the radiation treatment and go sort of all out. And if with an aggressive round of chemotherapy, you can maybe have a couple more months, right? Now, a few options might occur to you at this point if you are that patient. One is you might go through with the therapy and say, yes, I don't care what it takes. I would like to live as long as possible. One other alternative that might occur to you as that patient is you might say to your doctor, you know what? I've had all the chemotherapy. It's not pleasant. Famously, chemotherapy is no picnic. It makes you very, very sick. So I'll tell you what. I don't want any treatment. I'll just go out feeling, pretty good. And I don't want those extra few months if they're going to be just me laying around feeling sick all the time, right? A third option, however, might occur to some patients, might occur to you. It might occur to you that not only do you not want any sort of aggressive chemotherapy, but also the prospect of just sort of sitting around for a few weeks, letting the cancer kind of ravage your body and ravage your brain, that also doesn't sound like a lot of fun either. So it might occur to you that you say to the doctor, you know what, doctor, I don't want any chemotherapy, and also, can't we just end this now? Can't you just give me something, an injection or a pill that will just end my life, and we can do away, if it's already clear that I'm dying, that I will be dead very soon, why can't we just end this now while I'm feeling good, right? And this presents a particular kind of moral question, an ethical question for the doctor. Is the doctor allowed to be part of this? Does the doctor do something wrong if he or she gives a pill or gives a treatment to a patient that will result in the patient's death, right? So this is the major question surrounding the question of euthanasia. And James Rachel's says that actually euthanasia, there are two forms of euthanasia, two forms of ending a life to avoid suffering, and this is, first of all, there is active euthanasia. There is the active measures that we might take to end somebody's life. The doctor comes in and gives you an injection or gives you a pill that poisons you and puts you out of your misery immediately and painlessly. The other kind of euthanasia that Rachel says exists is passive euthanasia, and that is where the patient simply refuses any further treatment, any sort of life-sustaining treatments, right? And this difference is often described as the difference between killing and letting die. Active euthanasia is killing, and letting die is the patient refuses treatment, and we just let nature take its course, right? So now let's talk about the moral, about how we want to judge whether or not how we want to judge morally these two forms of euthanasia. So before I go any further, let's take a look at the notes for the first section. Euthanasia is ending a life to relieve suffering. And Rachel says there are two kinds. There is active euthanasia, that is taking measures to end a life, also known as killing. And there is passive euthanasia, that is ceasing life-sustaining treatment. And that is often described as letting somebody die, or letting nature take its course. So what are doctors to do? Luckily for doctors, at least doctors who are paying attention, there is somebody who is willing to take this decision entirely out of their hands, right? Doctors do not themselves have to make the moral decision about whether or not they are going to allow a patient or help a patient commit suicide, in effect. Doctors have a governing body that makes these decisions for them, right? So the American Medical Association is a private organization in the United States that is responsible for licensing doctors and nurses, and they are not a governmental body, so they can't put anybody in jail. What they can do is they can revoke somebody's license to practice medicine, right? So the American Medical Association license doctors, and they also draw up ethical guidelines that are meant to cover these very kinds of moral decisions. Not just these, but all sorts of ethical issues involved in medicine. But one issue that's hot on their mind is the issue of euthanasia, right? And whether doctors are allowed to help patients commit suicide, right? Or to take active measures to end a patient's suffering, right? And the AMA's position is very, very clear on this. The AMA they want, like I said, they want to take this kind of philosophizing, these kinds of philosophical moral decisions out of doctors' hands. And so what they do is they have a very clear, straightforward policy that is meant to clear up any of these sort of moral issues. And the AMA's policy is that passive euthanasia, that is allowing patients to refuse treatment, passive euthanasia is okay. That is permitted, the AMA says, as long as you have the patient's permission, or if the patient isn't in a position to make those sorts of decisions for him or herself, the decision makers making the decisions for that patient, they give their permission, right? So passive euthanasia is fine. The AMA says active euthanasia, on the other hand, killing, the AMA says is always wrong. It is categorically wrong. Doctors may never engage in taking active measures to end a patient's life, even when the patient consents, even when the patient is in fact maybe begging the doctor to take their life. The doctor can't be involved in anything like that, right? And the AMA's thinking here is very clear. The reasons for their position is pretty clear. Every doctor takes what's called the Hippocratic Oath, right? Whenever they get their medical license. The Hippocratic Oath goes back to an ancient philosopher named Hippocrates, who's the sort of the father of medicine, right? Not sort of, he is in fact. And part of the Hippocratic Oath that every doctor takes, the most famous part of the oath, is to first do no harm, meaning that above all, doctors need to pledge and swear that with as best as they can, they are not going to leave a patient worse off than when they found the patient, right? So, and the AMA takes it that very clearly, if I go to my doctor with a brain tumor and I leave in a body bag because of something the doctor did or something the doctor gave me, then I have, and the doctor has willingly done this, right? He's given me a pill and it killed me. Then the AMA says it's very clear that the doctor has violated the Hippocratic Oath to first do no harm. He's left me in worse shape than he found me, right? So the AMA is not sort of, again, this policy is meant to be a sort of flat categorical policy that's meant to sort of not sort of engage in any sort of nuance and not meant to take any sort of individual cases into account. You just can't. Doctors are just not allowed to take patients' life. Doctors and nurses, right? And if you maybe we have some maybe I have some students who have been in the unfortunate position of having to make some of end of life decisions for a family member, right? Somebody who's been in hospice care, for instance, right? And this happened just a few years ago in my own family with my grandmother. She had a stroke. She already had dementia, so she already had really bad dementia and kind of didn't know where she was, right? But then in the midst of that, she had a stroke, and the stroke was so bad that she couldn't move. I mean, she couldn't eat. She didn't know she had no sort of reaction to anything in the world, right? And the options for the family then were just to take her to hospice care, right? And wait, right? There was basically, she couldn't even feed herself, right? So it occurred to my family at the time, me included, that the most humane thing under these circumstances would be, I mean, it's not like she's going to recover, right? She's in her 80s. She already has dementia. She's not going to recover from this. The most humane thing to do, rather than just sort of let her waste away in hospice care over the next couple of weeks, the most humane thing to do would be to just put her out of her misery, right? But you can't do that, even in a situation as dire and as hopeless as that, because doctors are just not allowed, and neither are the hospice nurses, right? So, what do we think of that? Do we think the AMA's policy is right, or do we think it's wrong? Well, Rachel's has a strong opinion about this, and Rachel's thinks the AMA's policy is just wrong. It's flat out wrong. And Rachel argues that if the gist of his argument is that if passive euthanasia is okay, then active euthanasia ought to be okay, and ought to be okay for the very same reasons. In fact, he argues that active and passive euthanasia are morally equivalent. There is no difference between the two, and if it's okay to do one, it would be also okay to do the other, right? So let's then talk about what his arguments are. But first, let's go over the notes before I erase this. The AMA's position is that passive euthanasia, that's what PE stands for, passive euthanasia is allowed with the consent of the patient or decision makers, and active euthanasia is always wrong. Rachel's response to this is that the AMA is wrong. There is no moral difference, Rachel says, between active and passive euthanasia, and that if passive euthanasia is okay, so is active euthanasia. So now let's talk about Rachel's arguments for why he thinks the AMA is wrong. Now let's talk about Rachel's arguments that the AMA's position is wrong. There are two of them. So in the first case, Rachel says that, well, now go back to that cancer patient. Remember I talked about the cancer patient who had beaten cancer several times, that comes in, has a brain tumor, and now has just a few weeks to live, except with treatment. Could have a few more, could have a couple months maybe, right? But so what can the doctor allow? Well, the doctor can allow, according to the AMA policy, can allow the patient to reject treatment, right? The doctor can't offer to help the patient end the patient's life, right? Now, Rachel's asked, well, why is it that passive euthanasia is allowed in the situation, right? And typically, the reasoning on this is that it's allowed because we want to alleviate suffering, right? It's a hopeless case. The patient is not going to recover. And we want to alleviate the suffering, the gratuitous, unnecessary suffering the patient might endure, right, by prolonging life too long, or by having to suffer through chemotherapy during a lost cause, right? So it's the alleviation of suffering that makes passive euthanasia permissible, right? And Rachel's argument is very simple. He says, well, now wait a second. If we want to if alleviating suffering is what we're interested in, then we ought to allow active euthanasia, because that alleviates the most suffering, right? Because we can, a patient who rejects treatment then is facing a few weeks of letting the cancer ravage his body. That's going to be painful. Active euthanasia would alleviate that suffering, right? So, Rachel thinks, Rachel's argument points out that it would be wicked, it would be vile for a doctor to withhold treatment from a patient for some whimsical reason or some arbitrary reason, right? The patient could be treated, but the doctor just says, no, I'm going to withhold treatment from that patient, because I don't like the way he looks, right? Or the doctor arbitrarily makes a decision that the patient's life is not worth living, and so I'm going to withhold treatment from that patient. We all agree that would be evil, that would be wrong, right? But that's a case where withholding treatment is terrible. It's not terrible, though, when the patient gives us permission and we're withholding treatment to alleviate suffering, right? So it's the alleviation of suffering that changes this otherwise wicked act into something that's permissible, right? And Rachel thinks, well, we ought to use exactly the same logic with killing, right? That yes, it would be obviously wrong. It would be murder for a doctor to just sort of give a patient a pill that kills the patient, right? But if we're doing it for the purpose of alleviating suffering, and we're doing it with the patient's permission, then we ought to be. Rachel thinks we ought to be. It's just irrational to think that that's somehow categorically different from passive euthanasia, from withholding treatment, right? So Rachel's in the first case, in his first argument, he thinks that this distinction just doesn't make moral sense to really draw to say that there's a serious moral difference between killing and letting die just doesn't stand up to any scrutiny, right? And that the AMA's position makes us too averse to active euthanasia, to killing, and it makes us irrationally averse to active euthanasia, right? Rachel's second argument that the AMA's position is wrong is that in the same way that the AMA's position makes us too averse to active euthanasia, Rachel thinks it also makes us too okay with passive euthanasia. It makes us too accepting of the idea of passive euthanasia. And Rachel thinks actually there are some examples of passive euthanasia that are absolutely wicked and horrible, but that are justified, that are allowed under the AMA's policy, right? And his example here is pretty horrible, right? So Rachel's is writing this back in the mid 1970s. So this is before the era of a lot of the extensive prenatal testing that they have today, right? So back in Rachel's time, there was, doctors would find themselves in this situation sometimes that a woman would have a child, and the child would be born with Down syndrome, right? Down syndrome is a developmental disorder. If you're familiar with it, it leads to people having severe mental impairments, also some physical impairments, but pretty serious mental impairments, right? People to being mentally handicapped, right? So back these days, they do prenatal testings and so people know whether or not their child has Down syndrome, right? But back then, you didn't know until the baby came out, right? Now, commonly with babies that have Down syndrome also often comes with a physical impairment where the esophagus inside the baby does not quite hook up with the belly, or rather with the stomach. And so the baby can't get any nutrients, can't take in any food, can't take in any water, right? Now, this problem is fixed with a relatively simple surgery, right? All the doctor has to do is go in and attach it and sew it up, right? But the doctor needs permission to do that, right? The doctor needs the patient's permission. Obviously, in this situation, a baby, a newborn, can't give permission, right? So the parents are the decision makers for the baby, right? And the parents have the option, or had the option back in Rachel's time, sort of categorically to refuse treatment for their child, right? In the same way that a patient has sort of an unlimited right to refuse treatment. The parents had a right to refuse the treatment on behalf of their child, right? Now this results in the baby's death, right? The baby is then doomed, right? So, and Rachel's thinks that this is a horrible thing the parents have been allowed to do. They're making life and death medical decisions based not on the outcomes or the diagnosis. They're making a life and death medical decision here based on the fact that they don't want a baby with Down syndrome, right? And Rachel thinks that the AMA's policy and the way that it treats passive euthanasia allows the situation, allows the patient or the decision makers to, just as a universal rule, reject treatment, right? And considers that harmless, considers that no big deal. And Rachel thinks it is a big deal. We have parents here who are rejecting treatment for their child because they don't want a baby with Down syndrome. Not only that, it gets worse. It actually gets much, much worse, Rachel argues, that not only does the AMA's policy make us okay with passive euthanasia in a way that's pretty unsavory here, but also its problems with active euthanasia, its policy on active euthanasia, prevents doctors and nurses from doing the most humane thing here. The most humane thing here would be that, hey, we've already decided this baby is going to die and has no good possible outcome. The most humane thing to do would be to put the baby out of its misery, right? Well, we can't do that. That would be active euthanasia. So the only option the doctors have is to take the baby off to some part of the hospital where you can't hear it scream and just let it die. Just let it starve to death over the next few days, right? Rachel thinks that's just horrible. This is a horrible, evil situation, and he thinks you can draw a straight line from the AMA's policy to the parents being allowed to make this horrible decision, and the doctors and nurses being helpless to step in and do the humane thing, right? As a footnote on that, cases like this popped up a lot in the 1970s and 80s of parents refusing these sorts of treatment and doctors and nurses just being helpless while the baby, they can't kill the baby, they can't help the baby, and so the baby just has to scream itself to death over the next few days, right? In the mid-1980s, the Supreme Court heard a case, the famous Baby Doe case, and the gist of that is that these days parents aren't given that option. They're not allowed to reject that kind of treatment. The doctors just go ahead and do it, right? So, okay, so our notes then. Two arguments that the AMA's policy is wrong. One is that if relief of suffering justifies passive euthanasia, then it also justifies active euthanasia, since active euthanasia relieves the most suffering. Secondly, some cases of passive euthanasia, like the Baby Doe case, like the case where your parents are just refusing to allow doctors to do surgery, some cases of passive euthanasia are wrong, but they, Rachel says, are permitted by the policy. So next, Rachel turns to sort of mop up some that's sort of the meat of his article. Now he turns to mop up questions about whether or not we have remaining anxieties about his project here, right? First of all, the attendance password for today is planet, like what goes around the sun, planet. So. Rachel's next turns his attention to the question, well, but don't we have just a gut intuition that there is a moral difference between killing and letting die? And to this he deploys the Smith-Jones scenario. He says, now, well, okay, if you think that there just is that killing and letting die are just two sort of different moral categories, then consider this. And if you think that and then probably you think that it's worse to kill somebody than to let somebody die, imagine this scenario. Imagine there are these two guys in different dimensions, right, in sort of parallel universes. There is Smith and there is Jones. Smith and Jones, in their different universes, they both stand to inherit a large sum of money if a young relative dies, right? So they both plot to murder this child. They both sneak up the steps late at night whenever the child is taking a bath, I guess maybe in the early evening. They both burst through the door to drown the child in the bathtub. Smith drowns the child, but Jones, when he bursts through the door, realizes the child has already fallen, hit his head, and is now drowning in the bathtub on her own, and just does nothing. Doesn't call the police or an ambulance, just lets the child drown. Right? Now, Rachel's asks you, who's worse, Smith or Jones? And he'll answer for you. He thinks that our gut now tells us that Smith and Jones are both equally horrible. They've done all the same things. They've both plotted to kill the child. They both went about to kill the child. The child is dead. It's just happenstance. It's just an accident that in the Jones scenario, the child had already fallen and hit his head, right? So Rachel thinks Smith and Jones are both equally evil. They're both equally horrible. They both deserve whatever punishment we mete out to people who kill children, right? And so Rachel says, but wait, one of them killed, Smith killed, and Jones just let die. So shouldn't we say that Smith is worse than Jones if there is a difference between killing and letting die? And Rachel says, well, there isn't. Well, we don't, and so there isn't. He says he thinks that if you have an intuition that there is a moral difference between killing and letting die, that intuition just doesn't stand up to scrutiny. It just doesn't stand up to a lot of counterexamples. And so we should just lay it to rest, right? The gist of this, the bottom line of this, is Rachel thinks that doctors should be empowered to offer life-ending treatment if that is what their patient wants, if that's what's in the best interest of the patient. If the patient decides that I would like to not just refuse treatment, but actually would like to end my life painlessly, then Rachel thinks the doctor ought to be allowed to participate in that, and that the AMA should stop threatening punishments for that sort of thing. So let's take a look at these notes. So the question now is, but don't we have an intuition that there is a moral difference between killing and letting die? And Rachel says that tuition doesn't survive the scrutiny of the Smith-Jones scenario, right? This Smith drowning the baby and Jones just letting the baby drown, right? Therefore, Rachel says doctors should be allowed to offer life-ending treatment if that is what the patient wants. Rachel thinks that would be the most moral option, the most humane option for doctors, right? So now let's talk about some complications with Rachel's article. There's maybe some counter-objections. Or some counter-arguments. Okay, so now let's talk about a couple of difficulties or controversies with Rachel's article that have arisen over the years. Rachel's article, by the way, is kind of a classic of applied ethics. It's taught in virtually every kind of ethics class, introductory ethics class like this. It's in active and passive euthanasia is found in just about every ethics reader there is out there, right? So it's very widely read and very, very influential. Yet it was written in 1974. Now, decades later, the AMA's policy has not changed, despite the fact that philosophy students and medical students alike read this article from Rachel's, and so many people agree with Rachel's conclusion, if not his methodology. Yet the AMA has not changed its policy. Well, why? Well, I think there could be a lot of reasons. I think the two most important objections go this way. The first objection is going to be a philosophical objection, and the second one is going to be practical, right? So the first objection we can make against Rachel's is best sort of stated by Bonnie Steinbach, and I think her article, it might be in the ethics reader that we have. It's often paired with the Rachel's article. And Steinbach makes the case in defense of the AMA's position and against Rachel's. And the gist of her argument goes this way, that she says, well, Rachel's is he's just wrong. He's wrong from the word go on this, and he's wrong in large part because he's a utilitarian. To put the cards on the table, and now we have the now have the language for this. Rachel's is a utilitarian. He thinks that that acts are good to the degree they cause happiness, and bad to the degree that they promote misery. And Steinbach thinks that his concern, his, you might say, obsession with suffering and the alleviation of suffering clouds his thinking on this issue, because Steinbach argues that the AMA's policy has not one thing in the world to do with suffering. It's really about the consent of the patient, and it's about the autonomy of the patient, the patient being able to reject treatment and decide what happens to his or her own body, right? So when the patient rejects chemotherapy and says, well, I'm just going to let nature take its course, Steinbach says, that's not about suffering at all in any way. That's just about the patient deciding, I don't want, what's going to happen to my, me deciding what's going to happen to my own body. And on the other hand, the doctor not engaging in the practice of forcing a patient for his own good to take some, really painful or unpleasant treatment, right? And so Steinbach points out, well, Rachel's is wrong he's digging in the wrong place from the very beginning, because this isn't really an issue. He makes it all about suffering, and it's not about suffering. It's really about patient autonomy, right? That rearranges the furniture, I think, on Rachel's in Rachel's argument. I think that changes things up a little bit. Most importantly, though, are the defenders of the AMA's position are quick to point out that there are going to be practical implications of changing this policy. There are going to be practical implications on the ground for patients and for the family of patients. And before we rush into making sort of these big policy changes, we should think about what effects they might have. And I think a lot of people in the medical community are concerned that if we put doctors in a position of allowing patients to take their lives, right, of doctors being involved in getting them the technology that is going to take their lives and maybe taking the life for the patient, there are just a whole raft of unsavory ethical problems that might soon follow after that. I mean, in the first case, it's one thing for a terminal cancer patient to say to his doctor, I would like to take my life. But what if just a depressed patient comes to a doctor and says, I want to kill myself, but I don't have, I don't have the courage because I think it'll hurt. So I would like you to give me some pills that will put me out of my misery, or I would like you to inject me with something to put me out of my misery, right? So our comfortableness with patients being allowed, maybe even being allowed to demand that that doctors participate in their lives, very quickly seems to spread over into areas where maybe doctors, don't want to be involved in that. And this is the situation. This is where questions about euthanasia, and that's a question of a terminal patient wanting to end his life, quickly give rise to other questions about patient-assisted suicide, right? And they aren't exactly the same. Rachel selects very carefully his examples to be terminal patients who have no hope anyway, and why are we forcing them to live out the last few painful weeks of their lives, and doesn't want to talk about the depressed patient who just wants to use the doctor as a means to commit suicide. And this is a moral issue that arose, especially in the 1990s, in the era of Dr. Jack Kevorkian, right? Kevorkian was a doctor who had made a suicide machine, where patients could strap into it, put a needle in their arm, and he could put you out of your misery totally painlessly, right? And the problem that Kevorkian really got into is that what started out as arguments about, well, what about those poor cancer patients who just are tired and don't want to live anymore? Kevorkian was using his machine to help people who are just depressed commit suicide. And I think that people who are depressed and suicidal, that's a different sort of moral question, because with them there is always the hope of recovery. I mean, people do come through depressive phases, and then they're glad that they didn't commit suicide, right? Furthermore, there's the question about the other practical question that I think a lot of the medical community are really afraid of here is the pressure that might be put on elderly people, right? That the more comfortable we get with kind of death on command, the more comfortable we might get with putting pressure on certain elderly people to just call it a life, right? Consider a situation where an elderly woman, grandma, she's 91 years old, she's beat cancer 4 times, she comes in for a checkup, well, the cancer's back, so it's time for another round of chemotherapy, right? But rather than say, oh, well, I don't want to do that, doctor, grandma at 91 says, okay, fine, let's beat the cancer again, right? And she's all for it. She's all for extending her life for a few more years and racking up another, let's say, $200,000, $300,000 in medical bills, right? That her insurance company and or her grandchildren then are going to have to make good on, right? And a lot of people in the medical community, I think, are concerned that if you get too comfortable with allowing doctors to end their lives, that might soon turn into doctors and hospitals and insurance companies encouraging people in grandma's situation to just, be done with it already before you make life too difficult for us and your grandchildren, etc. Right? Better, the AMA thinks, and the people who defend their policy think, better to just not get into the business at all and just have a flat policy that prevents this in all cases, right? Even if, that leaves maybe some of our elderly people in a situation like my grandmother was in, which to me seemed an awful lot like the position that, by the way, that Baby Doe was in, or the babies were in that situation that Rachel's talked about, where there's nothing we can do for them, and we're not allowed, because of our ethics, to do the most humane thing for them, which is just it's a hopeless case, put them out of their misery. Instead, we just have to pretend that letting nature take its course is in the patient's best interest. That, I don't know, that seems perverse to me anyway. Yeah, but neither option is perfect. So that is it for Rachel's. Took up less time than it usually does. What we are going to talk about next is we are going to talk about Peter Singer's article, Famine, Affluence, and Morality. We can see that article as maybe an extension of some of the things that Rachel's is reasoning about here. So if we take this collapse of the moral difference between killing and letting die, and we think there is no moral difference between killing and letting die, and we think that that's true even outside of the hospital and outside of the specific issue of euthanasia, what does that mean? What does it mean to live our lives like that 24/7? And Singer is going to argue that actually that is going to have some very interesting and, for a lot of people, disturbing results. Okay, we will talk about that next time. Goodbye.